I think we can get started with our last talk of the morning. We have Lizzie who's going to talk to us about transgender medicine for the generalist. And thank you for being here today, Lizzie.
Thanks, Lauren. All right. So I'm Lizzie. I'm an R3. I use she, her, hers, they, them, theirs. And I'm going to be doing a talk about trans medicine as part of the transgender elective, which I recommend to anyone who's interested. I have no conflicts of interest or disclosures. Learning objectives are to overview key terminology related to trans care, overview health disparities in the trans population, talk about gender affirming hormone treatment, and then touch a little bit on trauma-informed care. So I'll just start with some definitions, which is how a lot of these talks start. Sex refers to chromosomes, hormones, reproductive anatomy, and this is designated or assigned at birth. Unlike gender identity, which really refers to a sense of self, attitudes, emotions, societal roles, and ways of relating to others. This is what a person themselves knows about themselves. That can be different from gender expression, which is presentation and includes clothing, hair, body, language, manner, and voice. This is what other people see. And sexual orientation, which is about attraction, is really entirely different. It may be helpful for people to know to counsel trans patients that when people go on gender affirming hormone therapy, about 1/3 of trans women and 1/4 of trans men have some evolution of their sexual orientation, and that's not always in the heteronormative direction. More definitions: gender non-binary or genderqueer folks tend to define their gender outside the binary construct of male-female. They may feel their gender is intermediate. They may feel that it contains elements of both. They may or may not define themselves as transgender as well. People who are gender neutral may feel between genders. People who are agender may feel the concept of gender doesn't fit them. And then people who are gender fluid may feel their gender is not fixed and that instead their gender changes over time. And I'll just draw attention to the fact that I use the word may here a lot to highlight the importance of not making assumptions. So these labels often mean different things to different people. And if you're unsure, just ask. A few terminology pitfalls. Gender affirming care is the appropriate term, not gender reassignment. And then I see this one a lot in the chart, but assigned male at birth or AMAB and assigned female at birth or AFAB are used rather than female to male or male to female. And the reason that we've ditched all of these older terminologies is that these older terminologies implies that the patients were one gender and are changing to another, when in fact how we think about them is that they've always been their gender. So that was a breeze through lots of terminology. Are there any questions so far about that? Let's see. I see something in the chat. Oh, okay. Thanks, Brandon. All right. So I guess I'll just quickly say, you know, trans medicine is something I feel quite passionate about, and that passion was really ignited during an infectious disease rotation I did as an R2 when I was first exposed to the degree of health disparities in this population. So I'd like to talk about that a little bit. This is the jaw-dropping statistic that everyone should know that I can't believe I didn't learn in medical school, that 41% of trans people have attempted suicide. That is about tenfold the rate in the general population. I'd say there are people who make arguments for and against gender affirming care, but you know, after reading that, there is virtually no risk of gender affirming medical care, with very, very rare exception, that would concern me more than the benefits of providing that care. This second statistic, which is also incredible, shows just how far we have as a medical community in providing this care. So when you look at the trans folks who were refused medical care due to bias, the rate of suicide attempt in that group increases to 60%. And one way of looking at this is, given the degree of bias in the medical community, it can be riskier and more harmful for trans folks to seek care than to avoid care. The rate of HIV infection among trans women is a whopping 14%. And when you look at Black trans women, the rate of HIV infection is 44%, which is just stunning. If you're a Black trans woman, you're about just as likely to have HIV as not. So these are some pretty shocking statistics, and I hope that they shock you all, and they're really only the tip of the iceberg. There's about a 50-page document with all of these disparities. With those disparities in mind, let's shift to talk a little bit about hormone therapy for trans people. So for those who desire it, hormone therapy allows trans folks to project their gender identity to themselves and to the world in a way that can significantly decrease dysphoria and dysmorphia. And a little segue for a little bit more vocabulary: dysphoria is a profound sense of unease or distress and can be accompanied by depression and anxiety, and dysmorphia is intense discomfort with a body part or feature. The next tenet is, treatment is individualized. So not every trans person wants hormones. Many people want hormones and don't want surgery. Some people want surgery and not hormones. And this is something we offer trans men who want top surgery but don't want testosterone. And then not everyone wants to end up on the same part of the binary. So not every trans man wants a huge beard and giant arm muscles. And not every trans woman wants, a curvy figure, and as one provider calls it, a J-Lo butt. For most trans people, it's about finding the right regimen where they feel good about their bodies and are happy. Overall, hormone therapy is very safe. There are some risks, which I'll discuss in more detail, but most providers would agree these pale in comparisons to the risk of withholding treatment. And as I've alluded to, the main negative outcomes result from withholding treatment or abruptly stopping treatment. And then finally, there's a lot of variation in how this is done. So I've tried to boil it down to the very main tenets. I will quickly say there are many more specifics about what to expect, basically, and how to do this than I'm going to go into here. And so if you're a PCP actually initiating and managing the hormones, I would refer you to the wonderfully detailed and far more colorful slides from Cam Chalker's presentation from December, which is in the AHD folder. So sort of broadly, the mainstay of masculinizing treatment is testosterone or T supplementation. And that's sort of it. There are two main formulations of T. There's an injectable form and there's a topical form that's a T gel. And the decision on the formulation is mostly based on patient preference with some caveats. So discussing, injections first, these tend to be the default for folks. And then the dosing is based on, I guess I'll step back and just say there is a significant paucity of studies and information on what actually happens in transgender folk. There just hasn't been a historical interest in doing research on them, and so the dosing for T is based on what happens when we give T injections to hypogonadal men, and this can be done every 4 weeks, every 2 weeks, or weekly. And what I've graphed here is the x-axis with weeks 1 through 4, the y-axis with testosterone concentration, and then the target range, which is what we call the normal cis male range, is graphed in gray on these. And on the top, you see if you give injections of 400 milligrams of T every 4 weeks, you would start below the male range, and you get this big peak where you're above range, a bit of time where you're in range, and then before your next injection, you've fallen below the target, such that people spend most of the time outside of the target range. Injections of 200 milligrams every 2 weeks result, as you can see, in the majority of time spent in the target range, but a bit of time just after injection above the target range. And then weekly injections of 100 milligrams result in basically 100% of the time spent in the target range. And based on these data, it was decided that the Q2-week injections provide the best balance of frequency of needing to inject with the amount of time in the target range. And just to be clear, this is the rationale for why we do the 200 Q2 weeks. We do not regularly monitor, or a lot of providers do not regularly monitor T levels because the response to testosterone is quite predictable. Benefits of injectable T: it's cheaper than other formulations. And then, as you could imagine, vaginal bleeding and menstruating for trans men is often very dysphoric. And injections are better than the gel at suppressing menses, so that's another benefit. And as I mentioned, there is some time spent outside the target range with the Q2-week dosing. So asking patients about cyclic symptoms, especially mood symptoms, is important if they're on the injections. The other commonly used formulation is daily topical T gel or androgel, which usually is given in a 1% concentration. It's applied with a metered dose pump, usually 2 pumps daily. And the gel generally keeps T levels in the target range, basically 100% of the time. Benefits: it confers less risk of polycythemia, which is the main risk of T supplementation. And the reason for that is that hematopoiesis is triggered when there are super therapeutic T levels, as happens here when there are injections. And so by staying in this range with the gel, you're getting less of that. And then, as I mentioned, the gel is worse than injections at suppressing menses. Just gonna quickly.
Quick question.
Yeah.
If you start at a lower dose of T injections with intention of up titrating, how often would you go up on the dose?
It's so variable. I generally see people sort of checking labs and reassessing things about every few months, so every 2 or 3 months, because it's not this perfect thing where after your first injection you reach your sort of baseline range. It will build a bit over the first couple injections. So there's no guidelines that are super clear, but every 3 months or so is what I would say.
And that's all the questions so far.
Great. Progesterone supplementation is one that people talk about for actually both trans men and trans women. It's quite rare in trans men, and is mainly used to suppress menses if T injections fail to do so. And that's because it's a negative feedback in the HBG axis centrally, and so it sort of suppresses the entire axis. The problem there is you actually initially get more bleeding because it also acts on the endometrium in trans men who have a uterus. And so while the endometrium is shedding, you usually get sort of a heavier menses, and that can cause, as you could imagine, even worse dysphoria. So that's not always the preferred way to do it. And then there's also some evidence that progesterones increase cardiovascular risk. So we balance that with the benefits and limit its use as much as possible. And there's actually some providers who have experience doing this. And if you just sort of treat temporarily for 4 to 6 months, the effects are sustained on the menstrual cycle. As I mentioned, we don't typically check T levels. So rather than checking, we titrate to the desired phenotype. And as mentioned, the main risk with T is polycythemia. So some people do check T levels. I'm not saying never do, but really the big thing to think about monitoring in these men is their H&H. So we'll check an H&H at baseline, usually about every 3 months when starting or titrating, and then about every 6 months thereafter. And generally I've seen a crit greater than 50 is sort of the spot where people start being concerned, and you really need to stop going up and think about decreasing if your crit is sort of like 52, 53. That is masculinizing. Any questions about masculinizing hormones before I switch to feminizing?
Question in the chat while others are thinking of questions. Progesterone in the form of an IUD, and wondering a little bit more about the progesterone and how that would impact dysphoria.
Yeah, I think that's a really interesting question. I didn't have personal experience doing progesterone on any trans men this rotation. There are trans men who get an IUD if that is something that they're comfortable with, and that can be a way to suppress menses as well. So that is certainly one of the formulations, absolutely. All right. Switching over to feminizing therapy, the mainstay of feminization is to treat with both an androgen blocker and supplement estrogen. And the anti-androgen helps decrease the dose of estrogen that we need, which is important for decreasing the risk of blood clots. And that's why these together are used. So the two main options for androgen suppression are either spironolactone or a GnRH agonist. Spironolactone works as an antagonist at the androgen receptor. This blocks androgenic effects like acne and hirsutism and male pattern hair loss. And as we know, it can also promote breast growth, given the side effect of gynecomastia. The main drawback is that it's a mild diuretic, so that's not usually the intended effect, and it can cause polyuria or occasionally electrolyte abnormalities. And then GnRH agonists like leuprolide work to suppress the HPG axis and therefore just shut off testosterone production sort of at the source. They tend to be quite expensive, and it totally depends on insurance and where you're getting care. But usually they're over $10,000 before insurance and still about $2,000 out of pocket after insurance for a lot of folks, depending on insurance. So that tends to be the drawback with leuprolide. And then estrogen, as I mentioned, that tends to be the riskiest part of really any of the hormone therapies because of the risk of blood clots. We use 17-beta estradiol, which is the formulation with the least clot risk, and it mimics the estrogen produced by the ovaries. As an aside, trans women who are denied care by physicians will often go on to purchase estrogen online anyway, and frequently the formulations that they are able to find are the synthetic estrogens with a much higher clotting risk. So refusing this care because of the clot risk isn't really a good way to avoid it. Most commonly, we start with like 1 milligram PO daily would be a typical starting dose, and then up titrate if needed to achieve the desired effect, but really with the idea being to give the lowest possible dose. For patients who are smokers or have some other increased clot risk, we usually use IM injections because they avoid first pass metabolism in the liver, so you don't get that high concentration in the gut, leading to a bunch of clotting factors. You're just injecting straight into the systemic circulation. And then progesterone, again, we see in trans women, it's not typically helpful for trans women either. The main end organ effect of progesterone in cis women is on the uterus. And given that trans women don't have a uterus, there really isn't an end organ where progesterone is acting. Because the brain has progesterone receptors, it does suppress the HPG axis and therefore T production in trans women. And so clinically, it is occasionally used for, I've heard it mainly used for suppressing erections in trans women who don't want them. Some do. And then, as previously mentioned, progesterone might increase risk for cardiovascular events and therefore should be limited. And it can, as with trans men, it can often have the desired effect if it's given for 4 to 6 months and then stopped. Any questions about feminizing therapy before I move on?
A couple questions in the chat. So clarification back to the cost you brought up. Is that $2,000 you quoted the monthly cost or?
Per dose.
Oh, okay. Oh, for a dose of leuprolide. Got it.
Yeah, that's a good question. I don't know how often it's dosed. It's not one that I saw, so I just have to look that up. I don't know off the top of my head.
No
Refer to CAM slides.
A couple doses then on estrogen, or a couple questions on estrogen. What is the dose of estrogen compared to OCPs, and what is kind of the relative clot risk at these doses? Do you have a sense?
Yeah. So this is a slightly higher dose than at OCPs. So I think OCPs are at like 0.5 milligrams in general. And so these higher doses are needed because they, the goal here isn't to prevent pregnancy, it's to shut down the HPG axis with that negative feedback. And so you do tend to do higher dosing than in cis women. And because of that, the clotting risk is higher. I don't have a good study, and this sort of goes back to the fact that there aren't studies on trans people, in a lot of the ways we would expect. So I don't have great study data on how this affects the relative risk of clotting. It's certainly, talking to providers, the main sort of effect that they do see. So they do have patients who have blood clots, and I don't have specifics on that relative risk.
Great. A question about if estrogen patches are effective, and thinking that they also bypass the liver.
Yeah. Any form of estrogen is I guess any form of estrogen that you think of as like a contraceptive form can be used. These are the ones that are most commonly used. And I don't actually know a whole lot about why the patch isn't used more often. I think, I'm not sure. I think in Cam slides, he talks about the patch as one of the options. Cam, you can chime in about. I just haven't seen those used in practice, so I don't know.
And then, so Cam is chiming in that people find the patch annoying, to be honest, potentially as one barrier. And then also just reiterating the point you're making about not many good studies looking at clotting risk. Our best understanding is that risk is overall low. Topical therapy reduces risk more, but just don't have enough data. And then the last question for now, any data on trans women using progesterone to increase breast size? Is that something you've come across?
Yeah, it is. This has typically been the reason that trans women seek progesterone therapy. Either they want the, hormonal milieu of a cis woman, and that includes progesterone, or there are some, even in trans women, there is some ductal tissue that does have P receptors and is theoretically progesterone responsive. There is some data looking at it, and I'd have to dig through to find the citation, but this was studied, and there was no significant increase in breast size for women on progesterone in addition to estrogen. So it hasn't clinically been borne out. There is some theoretical reason it might, but given the cardiovascular risk, at least the endocrinologists that I've talked to generally try to talk people out of it, explaining that it has, equivocal risks and clearly no benefit or no clear benefit for breast size. Great, okay. If there's nothing else, I'm going to move on to just quickly touch on trauma-informed care. So I really couldn't do a talk on trans medicine without discussing trauma-informed care. Just for context, most providers are cisgender and don't have personal experiences as trans. And when we reach from our own experience, we often make a lot of false assumptions, or in other words, our good intentions can often lead to bad results. And I would say gender is so fundamental to everything we experience that for those of us who are cisgender, we don't really understand how profoundly trans people are mistreated, misgendered, both in society and especially in healthcare. So to that end, the concept of trauma-informed care has been intensely promoted and emphasized by many of the providers who do this work and who I've worked with this month. And it is defined in the literature as a strengths-based framework that is grounded in an understanding of responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both providers and survivors, that creates opportunities for survivors to rebuild a sense of control and empowerment. I encourage you all to learn more about trauma-informed care, not only for working with trans patients, but also for working with any patients who have experienced trauma. So to that end, I'm going to briefly touch on some of the basic principles of trauma-informed care, and this list was adapted from a slide by Corinne Heinen. The first is identity affirming. This can be as simple as facilitating getting the EMR to reflect a patient's preferred name and pronouns, or providing resources for changing the patient's legal name. The other one I picked up from David Cummings, who's an endocrinologist at the VA, is he calls all of his patients clients rather than patients, because patients implies that they are seeking care for a disease. Empowerment is the second. Just some examples here. One of the most re-traumatizing or triggering aspects of healthcare for trans patients can be the physical exam, especially if they experience dysmorphia about the body part being examined. That can be their penis and vagina. It can also be their neck, or any other, or the cardiac exam, or any other body part. And if the patient is empowered to stop the exam at any time, if that's explicitly discussed with them, that can help build trust and reduce triggering. The next one is predictability and safety. For context, I think I've alluded to this quite a bit, but there's a really long history of providers inappropriately withholding gender-affirming care from trans people. So you can imagine many trans people are terrified of this, walking into each appointment or each lab draw. And one of the providers I worked with, Jonna Cuneo, who's an ARMP at Peter Shalet's clinic, when she discusses lab draws or the frequency of appointments during hormone therapy or whatever the plan may be, she states over and over that these are for safety, and that there's basically nothing a patient can do to suddenly make her withhold hormones. So missing a lab or something like that won't mean they're cut off from treatment. And just sort of saying that out loud to them can seems to create a very powerful alliance. And then lastly, elicit rather than assume the needs of a patient. So a trans man comes to you for gender affirming care. You very well intentioned and eager dive right in, and you say, first we're going to start testosterone at this dose and then check some labs, and you've got a big smile on your face and you're really excited to help. And The problem is that you haven't taken time to understand what the patient's goals are. And so the trauma-informed approach would be to stop and ask, what are the biggest sources of dysmorphia that you want to change, and what rate are you comfortable going at? And just sort of getting a sense of, what is most dysphoric and what they're comfortable with. Don't assume they want everything done. Don't assume they want everything done ASAP. Maybe they haven't told their families. Maybe they haven't told their coworkers. And so maybe easing into things would be preferred. The other things that you should always ask rather than assume, I feel like we talk about this a lot, but just to say it explicitly, what do you like to be called? What are your pronouns? And I've heard Corinne Heinen talk about this as universal precautions. So the idea being we really shouldn't be assuming anyone's pronouns. Just like we gel in and gel out of every room, we should be applying these ideas to all of our patients. Any questions about trauma-informed care or other parts of what I've said? Great. So that was a really broad overview. My conclusions are here. First, it's our job as providers to gain a basic understanding of key terminology and not assume anything. Health disparities among trans people, and especially trans people of color, are some of the greatest that exist in medicine that I've seen. To feminize, give T, monitor the H&H, with the risk being polycythemia. To masculinize, suppress androgens and give estrogen, and the concern there being, clotting risk. And then lastly, trauma-informed care is paramount to caring for this and many other populations. So I encourage you all to learn more about it. All right, thanks guys. Any additional questions that are lingering now? Thanks, Sheree. Great. I feel like I heard something in the background, but I'm going to stop sharing my screen. Cool.
Thank you everyone for such a great morning of talks. Those were all such great topics and so key to our practice. So that was a great day. I love this idea in the chat. We should get together a group of residents together for grand rounds for faculty. It's a cool idea. We've had some great talks on trans health this year, and I think they've all been really excellent. So glad we're talking about this stuff. Thank you all for participating today and being so engaged. I think if there's no more questions, we can go ahead and sign off, but feel free to shout any last questions out too as we go.